A? So A causes what? TV. Oh, I mean, somewhere when that area. Just because. So for me, right? We talk about two organisms that most of the time cause cervicitis. We talk about chlamydia and gonorrhea, right? And then those are STIs, and potentially, if we don't treat this, then it can start to progress up to cause a PID. And so PID, you're going to get that cervical motion tenderness. You're going to push on that cervix, and be painful. With cervicitis, when you push on the cervix, it's not causing that pain like you experience with PID, because the organs upstream are inflamed and infected. Make sense? All right. This was an FYI slide, but still you should kind of know it. Just perfect questions whenever it comes. Normal menstrual flow, what's that word? Yeah, so menorrhea. Dysmenorrhea, what does that mean? Painful. Painful menstrual cycle. Menorrhagia. A lot, right? Menorrhagia is not a word.
I was going to say.
It sounds like one. Menorrhagia. Timing, right?
I'll do that shit to me.
I'll pick it. I'll be like, yeah.
All right. Yeah, she has a little bit of vaginal bleeding. You do the ultrasound, you don't see any tissues of conception, you don't, the cervix is closed, you got to think what?
Threatened.
Complete, right? If it's threatened, that cervix will be closed. But when you do that ultrasound, you're going to see fetus placenta.
Closed.
If it's incomplete, what do you guys think? Right.
It'll help my shit.
All right. Like that? Yeah. So amastia, no breast tissue, right? No nipple, nothing there. Accessory breast, that's that one that is ixilla. Polymastia essentially means supernumerary breast, same thing, right? You have more than two breasts. Yeah, so these are staph and strep can lead to it, right? What's the primary process behind this? Like, what causes this though? Right. So if you're not fully excreting the milk out of the breast, you're gonna have stasis of that milk. Now these bacteria, either staph or strep, are gonna get in there and start causing that inflammatory reaction and causing that mastitis.
First time. Benign. Whoa.
We haven't talked about prolactinomas yet, we will today. But yeah, all these other features, fetal orange, painless lump, retraction, estrogen, those are all associated with breast cancer. Bilateral milky discharge is not. If it's unilateral, that's concerning. Typically, it's going to look either bloody or kind of clear, like serum type. And so, if it's white and bilateral, that makes us think less likely it's breast cancer. Most of the time, you're not going to get breast cancer in both breasts at the same time. So, it should be typically just unilateral. Oh, questions about that? All right, make sure again, your slide says updated 21 October. I had it updated last night when I was reviewing to the teacher today. And I just found some things that I wanted to clarify, so just make sure it says that. So we're going to be talking about the endocrine system, and we're really going to focus on kind of a lot of different things, right? We touched on diabetes already, so we won't really focus on that one. That's definitely an endocrine issue. But we're going to focus on pituitary diseases, thyroid diseases, parathyroid, and adrenal glands. So kind of shifting up to or focusing on pituitary. So you either have hyperpituitarism, where you have either too much of a hormone being produced, or hypopituitarism. We're going to talk about just diabetes insipidus. There are other ones out there, and when you get to endo next semester, she's going to go into detail about all those, but we're just going to kind of lay the framework so you get an idea of what that means. Before we do that, let's just kind of review some quick anatomy, talk about ways hormones are made. So you guys remember from A&P that we got the hypothalamus and we have the pituitary gland, right? The hypothalamus essentially controls the pituitary gland, and the pituitary gland makes hormones, depending on which one we're talking about, the anterior or posterior, and it sends out those hormones to act in the body. So when we're talking about the anterior pituitary, it makes a lot of hormones. It makes TSH, ACTH, which we'll talk about in detail here in a little bit. FSH and LH, those are the ones that act on our sex organs, like the testicles and the ovaries. We're not going to talk too much about that, but I'm going to talk about it just real briefly about one condition. Growth hormone, that affects the entire body. That's going to cause growth of our tissues. Prolactin, its main job is to act on the breasts, to stimulate them to make milk. And then we're not going to focus on the endorphins. That's all anterior, right? The posterior pituitary, that one transmits or releases oxytocin and ADH. We're not going to talk about oxytocin, but ADH is what we're going to kind of focus on when we talk about hypopituitary. The thing about the posterior pituitary is that the hypothalamus actually makes this hormone, right? Hypothalamus makes the hormone, and then it sends it to the posterior pituitary gland, and it stores it there. For the anterior, the hypothalamus essentially tells the anterior pituitary to make the hormone. That's just a little bit of a difference. Is it really that important? Not really, but I think it just kind of helps clarify some few things. So hyperpituitarism. So these are typically caused by pituitary adenomas, so benign tumors of the pituitary gland. We got several different types. We got lactose. These are those prolactinomas. So these cells are called lactose, right? And when you have too many of them, when they're growing, when you have a tumor that's opposed to them, they're going to release a lot of prolactin. Now, prolactin, like I told you guys, its main job is to tell the breast to make milk, right? But what prolactin does is when it's too high, it can actually shut down your FSH and your LH. So it shuts down those hormones that stimulate our sex organs. So when that happens, and it makes sense, right? When a woman is pregnant and she's menstrual and she's breastfeeding, she's not going to have a cycle. This is why, because that prolactin level is high, so we don't want a woman to become pregnant while she's still breastfeeding. So when this happens, she's going to have galactorrhea. She's not pregnant in this case, right? She just has a tumor. She's going to be making this bilateral monthly discharge, but she's not pregnant because that prolactin's high. She's going to have amenorrhea and infertility because she's getting that negative feedback to tell that FSH and LH not to be released. The prolactin's too high, so she's not going to have a cycle. She's not going to be pregnant. That could be a potential cause when a patient comes in and they are having difficulty having a child. That's one of those things that we want to check. In men, if we have a prolactinoma, they're going to have erectile dysfunction, they're going to have decreased libido, and they're also going to be infertile because, again, we're shutting down that FSH and LH. Those hormones stimulate the testicles to make testosterone and undergo spermatogenesis to make the sperm. So if we shut that down, they're going to have these issues. Now, there's a medication called bromocriptine. I'm not sure if Mark talked about this yet. Essentially, dopamine can actually shut down prolactin. Bromocriptine is what's called a dopamine agonist. So it's a medication we give to stimulate that prolactinoma to stop making prolactin. So if we give bromocriptine, which is a dopamine agonist, which normally in the body shuts down prolactin production, we can improve these symptoms. If the tumor is really large, though, it's really, really big, or we try to treat them with medication and it's ineffective, then they can go in and do surgery where they'll actually remove that tumor. So that's prolactinomas. Somatotroph adenomas, so these are tumors that cause increased amount of growth hormone. And so with growth hormone, think about it, it's in the name, it causes tissues to grow. It really kind of helps us to identify when this tumor formed. We can base that off of how the patient looks. So if it happens before puberty, right, pre-puberty, what's going to happen is that they're going to have gigantism, so they're going to be super tall. And that's because those epiphyseal plates, those plates that normally proliferate whenever we're growing, those things are still open before puberty, right? And so if we're giving growth hormone, we're going to have an increased amount of growth plate activity. So these folks are going to be very, very tall. And I'll show you a picture here. And I'm sure you see people who have this condition. There's a lot of famous people. After puberty, whenever the growth plates they close, right? They no longer proliferate. You're going to get something called acromegaly. So this growth hormone, it's going to still stimulate tissues to grow and bones to grow, but because the growth plates are closed, they're going to stop growing tall. What's going to happen is that their jaw is going to get thick. Their bones are going to thicken. So their jaw, their hands, their feet, they're going to start getting thick. So they have this very characteristic appearance whenever this happens. The organs are also going to get enlarged. A lot of these guys die from either cardiac or respiratory systems. So that's because of those tissues are too big, so they stop working well. The way we treat this is we got to remove the tumor. So as soon as we identify it, we try to take out that tumor, and if we stop that, well, then we can prevent these complications from happening. And then the last one, corticotroph adenomas. So these release something called adrenocorticotropic hormone, ACTH. We're going to talk more in detail about that towards the end of the lecture here. But this is very commonly associated with Cushing's disease, and I'll show you what I mean here in a second. So hyperpituitarism. So looking at the prolactinomas, right, that first block, it just shows you what a patient may present with. So they may have menstrual irregularities, or for a man, they may have erectile dysfunction, nipple discharge, low sex drive, infertility. So all those are causing issues with the FSH and LH, which is causing a lot of those symptoms. But then the prolactin is causing the discharge. And then gigantism. So Robert Wadlow. So I think you guys maybe have seen him. He's pretty famous. Or I think I've seen a lot of pictures. He developed the tumor, right? So he developed it before puberty, and so he grew super, super tall. And then versus Andre the Giant or Bigfoot Silva, they're still tall, right? But these guys still had this tumor after puberty, and so they developed that thick jaw, big hands, right? Really dominant facial features. But look at Robert Wadlow, right? He's very, very tall. But does his face look that dramatic? Does it look like a typical acromegaly person? Yeah, I guess so. Not really, right? Because it takes time for that acromegaly for those features to develop. And there's no old pictures of him when he's older because he died, I think he was 22. He actually died from he developed an abscess on his ankle and then he developed septicemia. So if he would have had time to, if they didn't treat this, if he would have had time for this to progress, he would have developed those facial features. All right, so hypopituitarism, so low levels of those pituitary hormones. This is typically due to a deficiency, right, of one or more pituitary hormones. We're only going to talk about diabetes insipidus. Talk about that in the next slide. Causes of this, so tumors. So if you have a pituitary tumor, you have a pituitary adenoma, what's going to happen? Things are going to grow. And that where that pituitary gland sits, it's in a very, very tight spot, the cell tertica, right? There's not a lot of room there. So when this tumor grows, it's going to start compressing on the blood vessels that feed it, And as a result, it's going to start causing ischemia, and eventually it can cause necrosis of that pituitary gland. And then if that thing dies, well, now you're not making any hormone. So that's one potential cause of this. There's something else, so circulatory disturbances. So Sheehan syndrome, that's a pretty rare cause of this. So what happens here is that during pregnancy, this is typically associated with pregnant women or who deliver. With pregnancy, you're making lactotropes to make prolactin, right? You have lactotropes, but they're growing in size. They're growing in size and number because their job is to make prolactin to make the breast make milk, right? The problem is that these lactotropes, they grow in number and size, but the blood that feeds the pituitary gland doesn't increase, right? And so you got an increased number of cells, but the same amount of blood that you had before you had this increased number of cells. So these things are just kind of, they're barely kind of making it, if you will. You have increased demand because you have more cells that need more oxygen, but you're not increasing the amount of blood flow to it. So if anything decreases that blood flow to them, they're at very, very, very high risk of not meeting that demand and causing necrosis or ischemia. So what can happen is that when a woman is delivering, there's there's always a big chance that she could have hemorrhaging. So we call that postpartum hemorrhaging, where she bleeds for whatever reason, could be a lot of reasons, while she's giving birth. When we do that, if she bleeds a lot, we're gonna decrease that perfusion because we're losing a lot of blood. And like I said, that pituitary gland is already barely making it because there's more cells, but not more blood going to it. So when we decrease that amount of blood going to the pituitary gland, we're going to start causing ischemia. If we don't correct it, we don't give this patient that blood flow back, then eventually it's going to lead to necrosis. And depending on the level of severity, you can take out that whole pituitary gland or you can take out portions of the cells that are in there. Most of the time, when patients have this, the first finding is that they're not going to be making breast milk because those lactotropes are the ones that are going to die first. And then if you don't correct it, then other cells start to die, so you start losing other hormones. And then trauma. Trauma is another big cause. So anything that causes trauma to the brain, significant traumatic brain injury can actually damage the pituitary gland depending on where that injury is, or if it leads to swelling. If there's swelling in the brain from that trauma, that's going to compress that pituitary gland and cause ischemia and cause it to die. Depends on the severity. If we can correct this, if we can fix it, maybe we can decrease that pressure, especially if it's from some type of traumatic brain injury, then we can potentially correct this. Because a lot of patients actually develop this from brain trauma. They get hit hard, too hard, for whatever reason, that can lead to edema, and then we have ways of trying to mitigate that, so we can potentially mitigate this, but the bottom line is trauma to the brain can potentially cause this. All right, so just focusing on diabetes insipidus. So antidiuretic hormone, that's that one that is in the posterior pituitary, right? So antidiuretic hormone, what do you guys think it does? It's kind of in the name. Retain water, right? So if we're deficient in antidiuretic hormone, we are not going to be retaining water. So normally what happens, kind of focusing on that bottom yellow box, so normally when we have too high of a sodium concentration in our blood, or we have low blood pressure, the brain, the posterior pituitary, releases antidiuretic hormone to increase the water reabsorption and to dilute the serum in our blood, right? We have to have a certain level, and if it's too high, we want to try to dilute that. If the body has low sodium or high blood pressure, then it's going to decrease antidiuretic hormone normally in order to try to concentrate the serum sodium, because we need a certain level of that, and potentially try to reduce that blood pressure. It takes a very, very high blood pressure for that to happen. If we are deficient in antidiuretic hormone, we're not making enough either due to trauma, if we have ischemia or necrosis to the pituitary gland or a tumor, then we're not going to be making it. And so as a result, we're not going to be holding on to water, and so these patients are going to be peeing a lot. They're going to pee, like it says, 2 to 20 liters a day, right? We don't even have 20 liters in our body. But what we're going to do, though, is because they're going to be losing so much fluid, we're going to give them fluids, because if not, we're going to dehydrate them. But if they're losing lots of fluids, kind of like diabetes, if we're peeing a lot, what's going to happen? You're going to get thirsty. Your brain's going to say, hey, I'm losing lots of fluid, it's time to increase my hydration. So these patients are going to have both polyuria and polydipsia. Now there's a test we can do if we're not sure what's going on, is that we can fluid restrict them. So typically these patients, they're inpatient most of the time, and we hold off giving them fluids, right? Normally when you hold off giving fluids, you're not gonna pee as much. In these folks, because we don't have this hormone, when we hold off giving fluids, it's not gonna affect, they're still gonna pee the same amount. They're still gonna pee the same amount as if they were drinking. So that's a good way to kind of test to see if this is the cause of the patient's symptoms. They're not going to have polyphagia. That's specific for diabetes, but they will have the polyuria and the polydipsia. All right, diabetes insipidus. It says up there without flavor. You guys know how to use the check for this kind of stuff back in the day? So that's why this doesn't have sugar, so it doesn't have it. All right, so thyroid diseases, so hyperthyroidism and hypothyroidism, and then we'll talk about loiters and neophytes. All right, so quick, just kind of briefly talking about how the thyroid actually functions, right? So in your hypothalamus, you have something called thyrotropin releasing hormone. So that's that hormone that stimulates the pituitary gland to release thyroid stimulating hormone. So TRH tells the pituitary gland to release TSH, right? TSH then goes to the thyroid and it tells the thyroid, hey, start making thyroid hormone. There's two hormones the thyroid makes, T3 and T4. T3 is the active hormone that actually works on the tissues of the body. T4 is like a precursor. It makes both of them, but when T4 gets to those tissues, those tissues convert it to T3, so T3 actually makes what functions. Is that important? Not really, but it's what you guys can understand that. Either way, TSH is telling the thyroid to make thyroid hormone, T3 and T4. When our body has enough T3 and T4, we're going to get a negative feedback to our pituitary gland and to the hypothalamus to say, hey, we have enough. Stop making these hormones to tell me to make T3 and T4. So it's kind of, it goes up and it goes down, and it's based on how much T3 and T4 is in the blood, and then it gets that signal back to the pituitary and the hypothalamus to say stop stimulating. That's how normally thyroid levels are kind of maintained. So with hyperthyroidism, so we're making too much T3 and T4, too much thyroid hormone at the thyroid. Autoimmune diseases are a cause of this. Remember Graves' disease? We talked about that first block. So we can make autoantibodies to the TSH receptors that are on the thyroid, and we can stimulate them. And when those autoantibodies stimulate those TSH receptors are going to tell your thyroid cells to make thyroid hormone. So you're going to have an increased amount of thyroid hormone. It's typically in adults, yeah, most of the time, I mean, very common in adults. Females higher, I think that's 10 times higher. I've definitely seen it more in females in practice than men. And then we talked about how autoimmune diseases like to come with other autoimmune diseases. So if they have one, they may have another one potentially. Another cause of hyperthyroidism is excessive thyroid hormone supplementation. So we can actually do this to our patients. So our patients that we are treating with thyroid medications, typically they have hypo, but we can overcorrect. If we give them too much thyroid hormone, we can cause hyperthyroidism. Now sometimes there are some drugs out there, right, that you get over the counter, or not over the counter, but at supplement stores that are weight loss pills. Those weight loss, those supplements, they're not FDA regulated. So you really never know kind of what you're getting. Sometimes they have some third-party certification, even that's kind of, I don't know, it's not always legit. Sometimes what some companies will do is that they'll actually put thyroid hormone in these weight loss pills, because if you increase that thyroid hormone, you can increase your metabolism so patients can lose weight with this. I think probably what's more common than what I've seen is that once the patient has had thyroid issues for a while and they're actually taking thyroid medications, they start to play with their medications for some reason. Not all of them do. Sometimes they'll notice that maybe I just need a little bit of a higher dose, or maybe I'm trying to lose weight for whatever, so they might increase it or something else. That's probably more typical. And then another cause is postpartum thyroiditis. So this is kind of a rare one where a woman is pregnant, and normally when a woman is pregnant, the immune system kind of tampers down a little bit in order to kind of not attack the baby. once a woman delivers, that immune system kind of goes into overdrive and it can actually attack the thyroid. When it attacks the thyroid, that thyroid is going to start releasing a lot of T3, T4 because it's destroying those cells. So you get this kind of real increased spike in your T3, T4 because the thyroid cells are becoming damaged. And over time, as that damage starts to go down, but the cells are pretty much destroyed, then you can develop a hypothyroidism. So that's kind of a weird one. And then benign thyroid tumors, we'll talk about more of that here in a little bit. So features of this, so they're gonna, think about it, thyroid hormone, its job is to increase their metabolism, to kind of make things go, right? So they're gonna be restless, they're gonna be nervous, they're gonna have tremors, they may have emotional liability, they may have mood changes, typically anxiety. Thyroid hormone causes our mitochondria to make more ATP. When we make more ATP, we're making more energy, but a byproduct of that is heat. So they're going to have heat intolerance, they're going to feel hotter. Because they're feeling hotter, their body's going to try to cool them down, so they're going to have excessive sweating. It's going to affect the heart for sure, so they may have tachycardia. They also may have palpitations, so it's not uncommon for a patient to have a fast heart rate or a normal heart rate and come in and complain of that. Exophthalmos and pretibial myxedema. So these are specific to Graves' disease. So they're not associated with supplementation and not associated with the other causes. This is only for Graves' disease. And I got a couple slides here that go in detail about that. But exophthalmos, essentially these patients have really bulging eyes. So when you can tell, they're either just kind of bulging out. And then the pretibial myxedema, that is essentially a swelling at the front of the shin. It also changes the way the skin looks. I'll show you a picture of that here in a second. So labs, right? So when you do labs, what do you think you're going to get? It says there, but you understand why. They're going to have a high T3 and T4 because they're making this thyroid hormone, but not from TSH, because we're either giving it to them, or most of the time with Graves' disease, those antibodies are actually telling that thyroid to make thyroid hormone. TSH is going to be low because TSH is what normally tells the thyroid to make thyroid hormone. And so if our T3 and T4 is being made autonomously, TSH is going to say, hey, stop doing this, stop making thyroid hormone, but it's not listening, right? It's not listening because that hormone is being stimulated by those antibodies. Okay? How do we treat this? So there's something called radioactive iodine ablation, 131, this type of iodine. Essentially what this does is we give this to our patients, and then this iodine can actually kill those thyroid cells, right? It goes to those cells that are making a lot of thyroid hormone, because iodine is needed to make thyroid hormone. When it kills those thyroid cells, though, we're not going to be making thyroid hormone anymore. And so most of the time, once we treat them with this, we have to start supplementing them with levothyroxine or Synthroid, like the thyroid hormones. If they have a cancer that's causing this, for example, which is pretty rare, but then we'll go in and we'll do surgical excision. We don't try to do surgery because it's a very risky area. They do it, but it's risky. And so we try to treat it with just the ablation, and that gets rid of the thyroid cells. In the meantime, while we're waiting to do the ablation, we can give them medications that will stop that conversion, that will essentially stop the production of T3 and T4. But that's a temporary measure. The way we want to treat this is with that radioactive iodine ablation. So here's what Graves' disease, right? Exophthalmos, so the bulging eyes. I don't think you guys necessarily need to know all the steps in this. Just understand that I think it's a good idea. I think it's good to know, but you don't necessarily have to know this. I would know exophthalmos is a sorry, but so fibroblasts. We talked about fibroblasts a lot. I feel like in this or in this course or something. Anyways, so fibroblasts are everywhere. Remember fibroblasts? They're the ones that make collagen and do all kinds of stuff. They scar tissue. Fibroblasts are also behind the eye. And these fibroblasts, they actually have TSH receptors. They actually have TSH receptors. And so if we're making antibodies, right, that mimic those TSH, it's going to stimulate those fibroblasts. Now these fibroblasts can change. They can differentiate and proliferate. They can grow in number and they can change into fat cells, adipocytes, and myofibroblasts, which their main job is to help make collagen and other things, right? If we have an increased amount of adipocytes, so fat behind our eye, that's going to increase that pressure back there. Normally we have some fat back there, but as these cells turn, as the fibroblasts turn into fat cells, we're going to make more fat cells that are going to increase that pressure. If we're making these fibroblasts, they're going to make more collagen, so more material back there to increase that pressure as well. These fibroblasts, they also like to attract, they also produce chemicals or a substance that likes to attract water, right? And so if we have this substance back there that's attracting water, so now we got fat cells, now we got connective tissue, and now we're increasing the amount of water that's back there. In a sense, it's going to lead to that pressure increase that's going to cause that swelling and that protrusion of the eye. And if we don't correct this, if we don't get this patient to an ophthalmologist, and there's different ways they treat this, that pressure is going to damage that optic nerve, and potentially these patients potentially go blind. And so the problem with this is that once we correct the thyroid issue, once we do that radioactive ablation, all this stuff is staying, right? It's not going to go back down. It's not going to improve once we take care of the thyroid. So that's why we got to get typically ophthalmology involved in this. So pretibial myxedema. So look at that top purple box. So mix means mucus, and then edema obviously means swelling. And I'll explain what I mean in a second. So there are fibroblasts everywhere. But the fibroblasts that are in our shins, or near our shins, also have TSH receptors. So whenever those antibodies stimulate them, they're going to start changing, right? Start causing changes, specifically at the shin skin. So they're making these water-attracting molecules. They're also making other proteins in the dermis and the subcutaneous tissue. Now, with these proteins, they act more like a gel. Think of it that way. And so this gel is actually what's holding on to the water. So you have more water there, right? But it's not like typical edema where you have the water in the interstitial space. This water is actually in a gel that these fibroblasts are making. And so whenever you evaluate this patient, they're going to have non-bleeding edema. So they're going to have edema. When you push on it, it's not going to leave that little kind of dough-like appearance, or it's not going to leave that impression. So this is different than regular edema. They also may have that thickened, waxy-looking skin. So it kind of looks like that pewter orange in a sense, right? That's actually what's happening here. You got this swelling. It's not from water in the interstitium. It's from water in this gel-like material that these cells are making. So you get these kind of little these indents. Same thing. This is not going to go away once we treat the thyroid. And so most of the time for this, we're getting them most of the time they're either with endocrinology or potentially dermatology, and there's different ways they can treat that. Typically steroids. All right. So hypothyroidism, so flipping, right? So now we have an underproduction of thyroid hormone, T3 and T4. Hashimoto's thyroiditis. That's a cause of hypothyroidism. Don't let that thyroiditis confuse you and make you think that it's hyperthyroidism. Hashimoto's thyroiditis is going to cause hypothyroidism, low T3, T4. It's the most common cause of hypothyroidism in the U.S., that's for sure. I've seen this a lot. And what happens here is that the body starts making autoantibodies against thyroglobin and thyroid peroxidase. Thyroglobin is essentially the precursor to thyroid hormone, right? Thyroid peroxidase takes iodine, which is needed to make thyroid hormone, and it attaches it to the thyroglobulin. Thyroglobin is there, we need it, but it's not doing anything. Thyroid peroxidase takes iodine, attaches it to the thyroglobin, and then it makes different T3 and T4. When we make autoantibodies to both of these, what's going to happen? We're going to start tagging them for destruction, and so we can no longer make thyroid hormone. This is more common in females for sure. It says adults 40 to 60. I wouldn't pay too much attention to that age range because I've definitely seen it in younger folks, but it can happen more so in older folks. So that's one way that hypothyroidism can develop. Another cause is thyroidectomy. So if we actually remove the thyroid to treat hyperthyroidism, or we do the ablation, right? If we do the ablation, that's going to kill off those thyroid cells, then we can develop a hypothyroidism. And then iodine deficiency in goiters, that's very, very common in other parts of the world, not so much here. But that's definitely one of the main causes actually in parts of the world that don't iodize their table salt. But either way, when somebody has hypothyroidism, they're going to have the opposite of hyperthyroidism. They're going to have decreased energy. They're going to have weight gain. They're going to be cold intolerant, cold sensitive. They're going to have changes in their mood. Depression is a big one. Hopefully, when you guys take psychiatry in a few weeks, that's one of the things that we should do as PAs when somebody comes in for depressive-like symptoms. We hear them, listen to them, but then we also want to rule out other potential causes. So typically what we'll do is check the thyroid hormone just to make sure that's not contributing. They're going to have bradycardia because those thyroid hormones stimulate the heart. So if we're not stimulating it, we're not increasing that metabolism, they're going to have a decreased heart rate. They're going to have generalized mixed edema. So this is generalized. So that's typically what's very, very, very severe hypothyroidism. Very rare that you're ever going to see this. But this is essentially body-wide edema, very similar to the pre-tibial mixed edema, but body-wide. And that's because normally T3 and T4 controls the fibroblasts. When we're not making enough of them, we're going to cause them to proliferate, so they're everywhere, so they're going to cause that mixed edema throughout the body. Definitely understand the labs with this. Definitely understand the labs with this, because labs are important with this. Understand the labs. So, with these patients, you're going to have a low thyroid hormone, right? You're going to have low T3 and T4. You're going to have a high TSH, right? So the pituitary gland is telling the thyroid hormone, hey, make thyroid hormone. It's not responding, so then the pituitary is saying, hey, make more, and so it's sending out a lot of TSH, but the thyroid is not responding. So you're going to have high TSH being made in the pituitary, but you're not making enough T3, T4. The way we treat this is with thyroid hormone supplementation, so Synthroid, levothyroxine, very easy to treat. Patients respond very, very well to this, so that's how we treat this. All right, so nodular goiters, right? This is another cause of hypothyroidism. More common, not in the United States, elsewhere in the world, okay? So iodine deficiency. So iodine is needed to make thyroid hormone. We need iodine to make thyroid hormone. And in places where they are deficient in iodine, where they don't have enough intake of that, those folks are not going to make thyroid hormone, so they're going to be hypothyroid. Now, here's what happens, right? So somebody's deficient. They have a very low level of iodine in their intake in their body, right? The pituitary gland is going to say, okay, we need to make thyroid hormone, TSH, go, tell the thyroid to make thyroid hormone. But there's not a lot of iodine. They're deficient. And so what's going to happen is that TSH is going to stimulate those thyroid cells to grow in number and get bigger. So the idea behind this is that we have our base level of thyroid cells. We have very little bit of iodine in our bodies. We're deficient. We're not able to make enough based off the number we have. So if we increase the number and increase the size, then that should hopefully counteract and make more thyroid hormone, right? That's what typically happens. We make more cells. We have more cells involved. They're making more thyroid hormone. We're still iodine deficient, but we have more cells to actually do the job. And so typically they're going to have a transient increase level of their thyroid hormone. That's only transient because as this iodine deficiency worsens, as they're continuing not to take in iodine, it's going to become low again. When we have an increased number of thyroid cells and increased size in the thyroid cells, we're going to develop something called a goiter. Goiter is just an enlarged thyroid. And initially it's going to be diffuse, so the whole thing is going to be enlarged, right? Over time, certain regions of the thyroid respond more so to the TSH, so you start getting these little nodules that develop. So initially you have a diffuse goiter, so everything feels nice and large and big, but then certain little regions in the thyroid respond more to it, so you start getting these little nodules that develop. So initially it's diffuse, and then over time it turns to nodular goiter. If this goiter becomes enlarged, it's going to start compressing on things. So it starts compressing your trachea, maybe cause a cough reflex. Hoarseness, so the laryngeal nerve, it sits right behind your thyroid. Whenever that thing increases in size and pushes on that nerve, those nerves control our vocal cords, right? And so if that happens, our patient's going to be hoarse, and so they're going to have this raspy sounding voice because that nerve is irritated. They're going to have the same hypothyroid symptoms, decreased energy, weight gain, cold sensitivity, so same kind of symptoms that the other one we talked about. The thing with this is that when you do your labs for this, the thyroid hormones, the T3 and T4, can either be normal or it could be low. If you catch it at a point to where it's able to make more T3 and T4 because it's being stimulated more, that's why it might be normal. But typically, if you give it time, it's going to start going low again. TSH is going to be high because it's telling, pituitary is telling the thyroid hormone, or the thyroid, to make more thyroid hormone. So TSH is going to be high. But your T3 and T4, think of it as low, but it might be normal. Okay? How do we treat this? We give iodine. Very easy. We can supplement them with iodine. They're going to have the materials that they need to actually make thyroid hormone, and then they're going to get better. The goiter, though, it could get better if you catch it in time, but if it's been prolonged, if it's been growing for years and years and years, then most of the time, if it's causing issues, we're going to actually do a thyroidectomy where we remove the thyroid. Okay, so thyroid neoplasms. So, I'm gonna talk about this, and then I'm gonna tell you something after we're done. Okay? Let's go ahead and take a 10-minute break. We're doing that time.
I mean, luckily for them, they're playing this open up 9. She's a little older.
This Friday, we're down here in 2 5 years. That's I've been in the field for 2 weeks, man. You're so good at something new. You're not actually thinking about it. That does sound nice, right? I started getting like really amazing like your eyes right out. She said they would hydrate. The early days, I have this like really thick, viscous, they gave me eyes at night, and it's like really cramped, and it's really butter. But I go to bed and I wake up and it's fresh. But because of the shutdown, all the pharmacies go back and they haven't shipped it. So now I'm just like, I'm like hyper-focused on like hydrate.
And then he turns around and his daughter is a window.
If you're not waking up like I am, I don't. Then you're fine. But I wake up, seriously, something to turn on the lights, like get dressed and shave, and I'm like, it feels like something's like it feels like a foreign body. Like, oh shit, something's in my eye. You guys have built it. Right? Yeah, that's right. So she said it's if you intentionally blink, we don't really blink like 100 times a minute, right? Like a lot. But when we're staring at shit all day, you bring that down to like 20 blinks a minute. So you just focus. So like over time, I can have the short term, like watching a movie or whatever. We do it day in and day out. We do it during class, like we will study the same shit. She said every 20 minutes, stare 20 feet away for 20 seconds and blink a lot. That only like laws and stuff, or is that like fucking ACOGs and below? Oh, really?
It's cool because it's starting to get cool in the morning. Well, it's like when it's freezing outside, it's like slightly better when the sun's out. Yeah, they have like, and those like Star Trek ones, like it has like all on like the right side versus like in the middle. They're submitting like plans for the new on-screen basis. Like that's what you need is new on-screen.
They have pictures of them?
No, they're like developing like the plans. I'm like, if you want to change something, give us like actual winners out. Give us warm.
Yeah.
Not fucking Walmart for bag. You're gonna charge me $125 for a PG jacket. That shit's no better than a Walmart bag. Yeah, I know it's nice. Like they actually have like a sweater. Yeah.
Yeah, I like that they've got.
Like you have a track jacket.
Yeah.
And then you have a sweater. Like you have off.
Yeah.
That is smart.
That's
Army's
nice.
all like, nah, dog. You get that shitty.
Naked 30. Jack.
Biggest branch, shittiest. It is bombing a yellow stripe on there. You don't keep. It's a built-in PC belt, but you still have to wear a PC belt.
Honestly, doesn't matter. So grateful.
You keep your hand in there. That keeps you warm. Apparently, I think the consensus was give us pockets so you can use it. And they're like, we got one even better. Not like you put like pockets. Yeah, like I always kept mine in my car, and I always put my keys in my gas cap. Like, I put it in my gas cap because I have no one thing. I'm not leaving like that happening.
I went at the trap for the occasion. I usually throw my keys like outside.
Yeah.
And then like I'm ready. And then I go look for my keys and I couldn't find them. This lady literally did a little boy from there.
Yeah, that makes it on. Got fans on it.
She's like, I think you can receive it. And I'm like,
You better go get it.
I got like a sticker pretty deep and I had like yeah, and then she's like, here's my just watch your fucking yeah. Let me get a good
Let me get my notes in.
I'm like, how do you not watch your kids like pick especially key?
Yeah, that's like.
I thought you said what he was saying. Like some bells going down with it.
Well, basically, I was living on base, so I think like most, I've been on base and it doesn't have a track.
And I think that's
Oh, the one that's going to be added. No, I appreciate that. I love that base. That base is good, like top tier.
Sir, what would cause that nodule? Like, we say it's mostly in third world countries with iodine deficiencies. What about just regular American person with a nodule? Same thing, iodine deficiency, but just around
Oh, I was just like, I'm not going I was a girl that year. I was in Gorilla at the yeah, first, most other schools in Miami had it. So like Gorilla had the animals. Yeah. So like I would listen to Gorilla. So we had all the livestock, and we also had we were also a dog rescue. So we had those. So I worked on the dog rescue, and then I shared with kids and like. I didn't have like I personally helped. I helped other people with theirs. I actually. So we had. You ever been up to Red? So like I was talking with that man. We literally had an actual school in the car.
What happened to the pig?
So that's your home. That's your home. Like, if you're like homesteading, which is like you raise your own stuff and you eat your own stuff, you have like farmers and ranchers that raise their livestock for like sell it for like. Well, farming is more of agriculture. So that's all you're
ready?
Ready.
Are you ready? So, few things, we need to clarify a few things. I think first of all, you guys are coming with good questions. That's very, very good. You guys are thinking like I think you should be thinking, because I'm telling you a lot of stuff here, right? And I told you guys at the beginning of the select, or the beginning of the block, first block, that I'm giving you kind of a high level overview of different things you're going to see until you get into the ologies and junior semesters. You guys are thinking correctly, so keep that mindset. If there's holes in what I'm explaining to you, come talk to me and I can try to fill those in for you. But there's a lot, I mean, think about it. There's only one slide really that talks about hyperthyroidism, or maybe two. There are books written on this, so there's a lot that goes into this. There's a lot out there to understand about this. So, again, I'm giving you just kind of high level stuff. If it's not making sense, it's not. Real quick with this one. So the hyperthyroidism. So this radioactive iodine ablation is only for Graves' disease. We're only going to use this for Graves' disease. We're not going. If we're given excess thyroid hormone, then what do you think we got to do to correct that? Stop getting it, right, or reduce the amount. We don't have to do the ablation for that one. The postpartum thyroiditis, I told you guys with that one that typically it's going to be a transient hyperthyroidism, and then over time this patient's going to become hypothyroid. Don't really have to know that. I don't think you have to for this, but this radioactive iodine is just for the Graves. So make sure that's clear. Okay. Did they talk about this with you in? I don't think it would, but radiology about these. Yeah. Oh, okay. Right. So these things can be done. They can be done. I will tell you more often what we're actually going to do is a ultrasound of the thyroid to look at nodules in the thyroid. We're not talking about ultrasounds in this block, in this series. I hope to add it in eventually. It's not going to be yes, but hope to add it eventually. So I'm just going to be talking about this radioactive iodine scan. Okay? So radioactive iodine scan, we use it sometimes whenever we're trying to identify whether a nodule is cancer or not cancer. There are other better tests we can do. This is one of those tests. Okay? The type of iodine we use is called 123. Does it matter? I don't think so. I mean, yeah, I guess so, because the other one is you wouldn't use this to try to ablate thyroid. So when we do this, right, what we're going to do is give the patient radioactive iodine 123. Whenever a thyroid cell is making thyroid hormone, it's going to take in iodine because they use iodine to make thyroid hormone, right? If a thyroid cell, if a nodule is not making thyroid hormone, it's not going to take up this radioactive iodine. So whenever it's not making thyroid hormone, it's not going to need this iodine, and that could be a couple things. Most of the time, whenever we do the scan and it shows up as a cold nodule, so it's kind of a white space in the thyroid, that tells us that there's no iodine uptake. Most of the time, that's associated with thyroid cancers. Okay? Can it be a benign thyroid tumor? Yes, it can. So thyroid tumors can also proliferate and not make thyroid hormone. But I want you guys to understand that thyroid cancers, whenever they do this, are typically cold. They're cold nodules. Okay? The hot nodule, so you got this nodule, and it's taking up a lot of iodine because it's making a lot of T3 and T4. It's making a lot of thyroid hormone. But what's happening to your TSH level? When you have this thyroid nodule that's just making thyroid hormone by itself, what's going to happen to your TSH level? It's going to go down, right? So because it's going down, the rest of the thyroid cells are not being stimulated to make thyroid hormone, so they're not going to be intaking that iodine as well. Does that make sense? So you got this one nodule that's doing all the work by itself without stimulation, but the rest of the thyroid is being turned off because it's not getting TSH because T3 and T4 is being made autonomously by itself. That's that hot nodule. Cool. The warm nodule, don't really worry about that. Essentially what the warm nodule is, these are typically benign nodules that you'll fill on. So you'll fill up a nodule on a patient. You may do this scan, and if it's warm, most of the time they're benign. Thing here is that it's still making thyroid hormone, but not to a level that's causing a suppression of that TSH. So it's not making a ton of it. It's making some, but it's not making a ton of it. What typically happens is that we catch this in the beginning. So we catch it when it first starts. It's a warm nodule. It's making thyroid hormone. And over time, it's going to increase the amount of T3, T4, and then eventually turns to a hot nodule. The warm nodule, again, don't really worry about. It's the cold and the hot that you really kind of should understand. Now, again, this is not one of those tests we commonly do, or it's really done a lot, because there are better tests out there, but this is still done, so it's good to have an idea of what this is. Make sense?
insert, just to clarify then, so for the hot nodule, or can I link that then to hyperthyroidism? And then like if I would see it, then it would just be what, just that one small area that would be?
You can do it that way. You can think of it that way. Yeah. 'Cause hopefully what I say here kind of clarifies it. So let's talk about thyroid neoplasms. So neoplasm just means growth, right? You can have a benign neoplasm or you can have a malignant neoplasm. Most of the time, and this is to your question about what we'll see here in the States, most of the time these are benign follicular adenomas, which are just benign tumors of the thyroid cells. That's what that means. There are cases where these can be malignant though, but most of the time, you feel a mass on the neck, it's going to be benign. Most of the time. When you're doing your physical exam and you're feeling that thyroid, my recommendation for you is when you're doing clean skills, have the patient sit down in a chair and then stand behind them to actually feel that thyroid. Don't try to do it up here because you're not going to really appreciate it. It's just something I think you guys should. I've seen it a lot here, but not here, but just in IPAP. But to really appreciate that thyroid, you want to make sure you're getting that whole thyroid. That's the best way to approach it. When you're doing your thyroid exam, you're going to feel a firm nodule. It's going to be palpable, depending on the size. If they're too small, maybe not. But if they're big enough, you're going to feel them. Patient may feel them first, and that's why they come in to see you. They potentially will have symptoms. If that nodule is growing too big, if you compress that nerve that sits behind the thyroid, it can cause hoarseness and voice changes. If it gets really, really big, it can start compressing on the trachea down to the esophagus and cause dysphagia or pain or trouble swallowing. Feel like tight in the neck because you just have this mass there. This variable involvement of the regional lymph nodes, that's specific to cancer. If you have a benign follicular adenoma, it's not going to metastasize. So this regional lymph node is specific to cancer. Because thyroid sits here and if it starts to metastasize, it can go to the lymph nodes. So benign follicular adenomas, these are common benign tumors, normally present as one nodule. They can be multiple, but typically one. And most of the time when these things form, they're not going to produce thyroid hormone. So then when you do your thyroid scan, it's going to be a cold nodule. But the problem is that cancers are also typically cold nodules. So it's not a very good test to tell whether or not it's cancer. That's why there are better tests out there. In order to confirm, we see this nodule, say we do the thyroid scan or the radioactive scan, you can't tell it's cold, okay, what does that mean? We're going to actually do a biopsy. We're going to send them to ENT, and ENT is going to biopsy that nodule, send it to pathology, and kind of see what kind of cancer it is, or if it's benign. If it's benign, we will leave it alone potentially, depending on how big it is. If it's causing symptoms, then maybe the ENT docs will actually remove that piece of the thyroid. But typically, we just try to leave it alone because can it get bigger? Yes, and if it does get bigger, then we'll remove it. But if we can avoid surgery, we will. Less commonly, it could be a functioning thyroid cell. So it could cause T3 and T4. It can cause hyperthyroidism. It's less common, but it can do that as well. So you can have either underfunctioning or overfunctioning of these thyroid nodes. You just don't know which one you got. So it's going to lead to hyperthyroidism, and then when you do that scan, because it's making so much T3 and T4, it's going to suppress your TSH, so the rest of the thyroid scan is going to be white, except for that one nodule, which is hyperfunctioning, which is making T3 and T4 without stimulation from TSH. Okay? Okay. This slide right here. Do not focus too much on the slide when you're studying. It's good to know. It's good to know that there's different types of cancers, but spend your time elsewhere studying for this excess. Because it's very kind of hard, based off what I have here presented, to really delineate what is what, to ask a question on this. I'm not saying that you won't see these words. Again, you may see these words, but just don't spend your time elsewhere studying on other slides. The main thing I want you to get out of the slide is that most of these malignant types of thyroid cancers present as nodules, and they're going to be cold nodules, because these cold nodules, these thyroid cancers, whenever they form, they don't make thyroid hormone. start to become undifferentiated. So when they become undifferentiated, they can't do those things that a normal cell does. So they're not going to be making thyroid hormone. So they're going to be cold. They're going to be cold on that thyroid skin. Papillary is the most common. Yes, that's true. Anaplastic is the most dangerous, and we treat that a little bit differently. We're going to actually remove that thyroid, the whole thyroid. We're also going to do radiation to the neck just because it's so aggressive. But that's pretty much it. That's what I want you to get out of it. When you get to endocrinology, they're going to go into great detail about all of these. I just feel like this needs some, I need to add more stuff. Okay? All right, parathyroid diseases. So hyperparathyroidism and hypoparathyroidism. So the parathyroid glands, those sit in the thyroid, but they're not made of thyroid cells. They're different types of cells, but they're in the thyroid. When we have a parathyroid gland that's making too much parathyroid hormone, PTH, it's going to cause a lot of issues with our calcium, because parathyroid's job is for calcium homeostasis, to balance out our calcium in our blood. Whenever we have too much parathyroid hormone, it's going to stimulate those osteoclasts, which are going to start breaking down calcium from the bone. So we have osteoclasts being stimulated by PTH. We're having a high amount of calcium in our blood. It also acts on the kidneys to tell them to reabsorb more calcium. So its job is to regulate the calcium, and so we tell them, hey kidneys, stop urinating out calcium, I want you to absorb more. So now we have more calcium going into our blood. It also tells the kidneys to make vitamin D. That's where vitamin D is part of the process of making vitamin D. Whenever the kidneys start making more vitamin D, it tells our intestines to absorb more calcium. So again, PTH's job is to calcium homeostasis. When we have a high level of it, we're going to have high blood calcium. This is most commonly due to a benign parathyroid adenoma, so benign tumor of the parathyroid gland. Most of the time, we're going to find this on accident. We're going to be doing a patient's annual blood work, or a BNP or a CNP, and we see high calcium, and we're like, why is that? And then we work it up further, we figure out, and we know things that can cause high calcium, and then we identify this. The problem with this is that if we don't catch it, and we start taking out too much calcium from the bone, we can develop these things called pathologic fractures. All that means is that you develop a fracture from something that normally wouldn't cause a fracture. I had a patient one time, she didn't have this. She had metastasis of breast cancer to her bone. She was on a flight, she went to go sit down in the chair, and she broke her arm, she broke her humerus. So that's a pathologic fracture. You're not normally going to break your arm by just sitting down in a chair. This can cause that as well. Because we're taking out that calcium from the bone, we're weakening it, and so these patients develop fractures that normally wouldn't cause fractures. Multiple kidney stone formation. So even though the kidneys are reabsorbing more calcium, you still have a lot of calcium in your blood. And so we're still urinating more calcium than we would, even though we're trying to absorb more of it. So these guys are going to have more calcium in the urine. And I told you that calcium, when the concentration becomes too much in the urine, it's going to start to form stones. So these folks can definitely get kidney stones. When you do labs, you're going to have a high serum calcium, so hypercalcemia. Parathyroid hormone also controls how much phosphate we absorb. So this one, because we have a high level, we're going to actually get rid of phosphate, so we're going to have a low phosphate level in our blood. So high calcium and low phosphate is associated with hyperparathyroidism. In order to treat this, we typically, especially if it's a tumor, we're going to remove that gland. Most of the time, just one gland. So if we can just take out that one, then this will correct it, and the other glands will still work and still do their job and compensate for that one that we took out. All right, hypoparathyroidism. So this is rare, and the most common reason why this happens is because we do something to cause damage to the parathyroid gland. Typically, it's associated with whenever we're doing a thyroidectomy, whenever we are removing the thyroid, we accidentally take out the parathyroid gland. There's ways, whenever they're doing a thyroidectomy, to essentially cut around the parathyroid gland and leave it in place, parathyroid glands, leave them in place. If we accidentally either damage the blood flow to it or take them out altogether, now we're going to have hypoparathyroidism. most of the time when they actually do the surgery is that they'll take out the thyroid, they'll dissect the parathyroid gland, and they'll actually put it in the sternocleidomastoid muscle. So they'll actually attach it there. So that kind of serves as its home. They get blood go into it. That's how they normally try to preserve parathyroid glands. We have low PTH, so you have low parathyroid hormone. The osteoblasts are going to increase. They're going to increase in their job. Their job is to put calcium into the bone, right? And so they're also going to inhibit calcium reabsorption from the kidneys. They're also going to decrease the vitamin D creation by the kidney as well. So the big thing is you're going to have a low calcium level with this because osteoblasts are putting it back into the bone or leaving it in the bone. Kidneys are not reabsorbing it, and vitamin D is not causing the calcium to be absorbed in the intestines, and so you're going to have a low calcium level. Now, calcium is very, very, very important in controlling our nerves and our muscles, which control our nerves, right? Our nerves control our muscles. If we have a low level of calcium, our nerves become hyperexcitable, right? So anything that normally wouldn't trigger them, if it's low, could trigger them. And so what can happen is that you can have muscle cramps, spasms, because calcium is essentially lowering that threshold to stimulate that nerve. So something minor will stimulate that nerve, which will stimulate those muscles. So they may have twitching, so they have twitching in their face, their eyes. Potentially it could lead to seizures, especially if we're causing issues with the nerves. Anybody speak Russian? How do you say this? C word. Is it Russian? I've seen it pronounced a whole many different ways. I learned it as chopstick sign. I've seen it pronounced as caustic sign, and I've also seen it pronounced as optic sign. That's so. However you want to say it, okay? There's one way to say it. Chopstick sign. It's called a chopstick sign. So what happens here is that whenever, so this is a sign you get, you can look on a patient whenever you tap their facial nerve, they're going to get this twitching around their eye. That's one of the signs. So typically when you tap there, you're not going to have twitching. But because those nerves are hyperexcitable, when you tap that nerve or the facial nerve, you can cause that eye to start to twitch. Trousseau sign, so this is where they put a blood pressure cuff on a patient, and then it causes something, it causes wrist and hand flexion. It's called carpal pedal spasm, or carpal, what? I don't know. It causes wrist and hand flexion. I'll think of it later. I don't know how they discovered this because the way you do this is actually you have to keep that blood pressure cuff on for like 3 to 5 minutes before this happens. Normally we don't do that. Somehow they found this out back in the day. But again, if we cause ischemia by putting that pressure cuff on that brachial artery, it's going to cause those nerves to become hyperexcitable. So the hand is going, and the fingers are going to flex like that. And they're going to have paresthesias because we're affecting the nerves, so they may have tingling in their hands and feet. They also may have tingling around their mouth and tongue. So those are all signs that maybe you have a low calcium level. Now I told you, so essentially it's the opposite of hyperparathyroidism. With this one, you're going to have low calcium, right? But you're going to have a high phosphate level. You're going to have hypocalcemia and hyperphosphatemia. The way we treat this, we give calcium, vitamin D, and we can actually give them synthetic PTH. We have medications that act as PTH. We can give this to our patients. Ideally, we don't destroy the parathyroid glands, but if we do on accident, we can treat it. All right, adrenal diseases. So adrenal cortex, you guys are familiar that there's 3 layers to the cortex, right? And then on the inside there's the medulla. So you have the cortex, 3 layers, and then you have the medulla. So Cushing's disease, and Cushing syndrome. So both of these problems are due to a high amount of cortisol, hypercortisolism. If it's due to a pituitary tumor, so if you have a pituitary tumor that's producing too much adrenocorticotropic hormone, ACTH, that tumor is making ACTH, and that ACTH is then going to the adrenal glands and telling the adrenal glands to make more cortisol. Okay? Cortisol is essentially a steroid, very similar to prednisone and other types of medications. They cause a lot of issues if you have too much of them. That's one way this could happen. If it's due to a pituitary tumor, we call that Cushing's disease. It's called Cushing's disease. It's different than Cushing's syndrome. Still same symptoms, but we just call it Cushing's disease. If you have an adrenal tumor, so if you have a tumor in the adrenal cortex, and that's causing too much cortisol production, then that's also going to increase the cortisol level. And so again, that's called Cushing's syndrome. But the thing with this is that your ACTH is going to be decreased because you have this tumor in your adrenal cortex that's making cortisol by itself. It's not getting any type of signal from the pituitary to make it. And so the ACTH is going to say, hey, stop making cortisol. The tumor doesn't care. It's making this cortisol without any type of stimulation. If you're taking exogenous corticosteroids, so prednisone is the big one. We give this to a lot of patients. If they're taking it for too long, we can shut down our body's production of cortisol because we're essentially giving it to them exogenously. And so that too can also cause hypercortisolism. But same thing, you're not going to have an increased ACTH because that comes from the brain. If we're taking it, and our brain says, hey, I don't need you to make it anymore, so it's not going to stimulate the adrenal gland. It doesn't care because we're still giving it to them by pill, by mouth. And we give steroids for a lot of reasons, autoimmune for sure, lupus, asthma, all kinds of things we give steroids for. So features of this. So whether it's Cushing's disease or Cushing's syndrome, they're going to have characteristics. They're going to have central truncal obesity and a moon facies and a buffalo hump. So what cortisol can do is that it can actually change the way the fat is distributed in our body. So it actually break down the fat in our arms and our legs. We have these very skinny arms and legs, but then it sends that fat to the face, to the trunk, and to the back of the neck. And so it's very characteristic of Cushing's disease and Cushing's syndrome. Cortisol also causes breakdown of collagen and proteins essentially, so it's going to cause skin thinning. So whenever you see a patient's face, it's going to appear their erythemas are red because you can see those capillaries. Skin is thinner, it doesn't have a lot of collagen in there. So their face appears red. They're going to have cutaneous striae, so they're going to have stretch marks because that collagen is being broken down. The skin is going to be able to make stretch marks because you don't have that support anymore. And then muscle mass, it's breaking down collagen, it's breaking down proteins, so we're taking those proteins from the muscles. Essentially what's happening here is that glucose or cortisol causes gluconeogenesis. That's where you make glucose from other things that are not glucose, right? So it's taking this protein, it's converting it into glucose. So we're taking it from the muscles, we're taking it from the skin, and we're making a lot of glucose. They're going to have facial hair and acne. I need to switch it around. Facial hair, so for women, facial hair is called hirsutism, and then acne is not hirsutism. Facial hair is hirsutism. That's another word for that. And acne is just acne. But what cortisol can do is cause an increased amount of androgens in females, so they can start to develop these male characteristics, especially facial hair, so hair in the chin, around the jaw. That's pretty typical. And then cortisol also impacts the way hair grows. It kind of shortens the hair growth cycle, so these people can have thinning hair and scalp hair. How do we treat this? If it's a tumor, pituitary tumor or a adrenal tumor, then we remove the tumor, right? If it's from exogenous steroid use, if we're giving them medications that are causing this, then we're going to take away that steroid, but you have to be. So if you give a patient a steroid for 5 days, that's fine, right? Not a big deal. The longer the patient is on the steroid, weeks, months, maybe years, the body stops making cortisol, right? Because it's getting it from pill. So when you cannot abruptly just stop corticosteroids. You cannot do that. Because if you do, the body needs time to actually restart making its own cortisol. If we take it away too quickly, we don't give it enough time to do that. Cortisol is super important, very, very important for us. There's a lot of things. I'll talk about here in a sec, but bottom line is you have to slowly take them off the steroid. You can't just do it like that. If you do, they're going to have a lot of problems. So here's what Cushing's syndrome and disease looks like. You got the moon facies, red cheeks, buffalo hump, that fat pad in the back, thin skin, thin arms and legs, striae, all kinds of things. I had a patient who I thought had this one time, but she didn't. Top row. He was upset. She was upset she didn't have it. So, anyway. Okay. Adrenal insufficiency. So here, the problem is that our adrenal gland is being attacked. Autoimmune disease, right? And the adrenal gland makes cortisol, but it also makes aldosterone. Remember we talked about aldosterone, the angiotensin-aldosterone system? Both of those are very, very important. So when we start to destroy the adrenal cortex from an autoimmune disease, it's going to slowly stop the production of cortisol, and it's going to stop the production of aldosterone. It takes time for this to happen. It's a slow progress, and it takes a lot of that adrenal cortex to be damaged before you actually see this in the patient. These patients are going, so JFK, he had this. You guys knew that. That's why he looked so tan. He wasn't going tanning. And I'll explain why that here, what caused that here. So if without cortisol, we're not going to be making glucose, right? And we're going to be intaking glucose, but during those times when we're fasting, or say we're really, really sick and we need more sugar for energy, we're not going to have that because cortisol is released whenever really we're fasting in order to keep our blood glucose at a normal level. So it takes proteins, it takes fats, and it converts that into glucose. That's what cortisol does. If we don't have this, then they're going to feel weak because they're not having glucose, they're not making energy, they're going to feel fatigued. It can also cause issues with our GI system, so they may feel nausea and have weight loss. Cortisol controls our appetite as well. So if we have a low level of it, we're not going to feel hungry, so they're going to start losing weight because they're not eating. There's bronzing, hyperpigmentation of the skin. So ACTH, right, we talked about that, is responsible for telling the adrenal cortex to make cortisol. ACTH and something called melanocyte-stimulating hormone, they share a common precursor. So they both start from this common precursor, and then one transforms into ACTH and the other one transforms into melanocyte-stimulating hormone. When we have a lot of this precursor, because ACTH is ramping up and telling the adrenal cortex, hey, make cortisol, the cortex isn't listening because it can't, because it's being destroyed. We have more ACTH, but we also have more of this melanocyte-stimulating hormone, and this hormone is what causes the melanocytes in our skin to make that color. So because we have more of essentially both, these patients are going to have a tan appearance to them. That's why they look this way, because they're making more melanin, which is causing them to become tan like that. So I talked about aldosterone a few blocks ago, how it's important in sodium in water, right? Aldosterone tells the kidneys to hold on to sodium in water. If we're not making aldosterone, which is made in the adrenal cortex, we're not going to be holding on to sodium in water, so we're going to have salt cravings. Our body's going to say, hey, I need salt. We're going to have this craving for salt. If we're losing fluids because we don't have aldosterone holding on to water, then they're going to develop hypotension and potentially syncope if the blood pressure drops too low. One way we can check for this is by doing a test called adrenocorticotropic hormone challenge test. Essentially here, we give the patient synthetic ACTH, so we give them that hormone, and then what should happen is everything is working normally. If the adrenal glands are working normally, there should be a rise in the cortisol level. If there's not a rise, that tells us that the problem is at the adrenal gland, and that's characteristic, diagnostic for Addison's disease. The way we treat this is we're going to give them lifetime corticosteroids. We're going to give them steroids because they're not making enough. We're also going to give them mineral corticoids. Don't really need to worry about that. That's essentially aldosterone. But the main thing we want to do is treat their cortisol, and so we give them corticosteroids, whatever it may be. There's different kinds. These guys, so we talk about Brown's diabetes when we talk about hemochromatosis. These guys are going to have a low glucose level. Remember hemochromatosis? Remember that? It's going to destroy the beta cells. These guys are going to have low glucose because they're not making that cortisol. So here is just a quick picture of kind of telling you where things are made. Don't necessarily need to know the zones, I don't think you necessarily need to. I think it kind of solidifies things. And then here's a picture of a lady who has Addison's. So before, she looked normal. Now she looks tan. I don't know. Anyway. All right, last one, pheochromocytoma. These are, people love to talk about pheos. They're out there, definitely. There was actually a student here who had this. I wasn't here for it, but one of the instructors found this in one of the students because they were telling them about their symptoms and they had this. It's one of those rare things, but it's important because if you catch it, like you're a star. It's just something that if you catch it, you make sure you tell everybody. So the problem here is that you develop a neoplasm in the adrenal medulla. So that center part of the adrenal gland, right? That adrenal medulla is responsible for making the catecholamine, so making epinephrine and norepinephrine. When you have this tumor there, it's going to release large amounts of epinephrine and norepinephrine. Now, epinephrine and norepinephrine, they come on fast and then they go away fast, right? So if you've ever been scared, you got scared real quick and you felt that, that adrenaline rush, then it goes away after, a few minutes, few seconds, most of the time. That's what happens here, but you're making more of it, so it's going to take a little bit longer for this to go away. But you're going to just be sitting there, or a patient will be just be sitting there, and all of a sudden they feel like they got scared. And it takes time. It's going to go away pretty quickly for this to go away once the bite starts breaking down the epinephrine and norepinephrine. When this happens, though, it's abrupt, so it's called paroxysmal. So abrupt, paroxysmal, same thing. It happens quickly. They're going to have hypertension because epinephrine and norepinephrine cause vasoconstriction, so the blood pressure is going to be elevated. And this classic triad is very classic. It causes headaches, so you increase the blood pressure, you're going to cause a headache from that increased pressure. Diaphoresis, so those epinephrine and norepinephrine stimulate the sweat glands, so you're going to have sweating. And the tachycardia is going to stimulate the heart, so you're going to have tachycardia and also palpitations. That's another thing. And then as that tumor gets bigger, symptoms are going to get worse. So it may be subtle in the beginning, and as that tumor starts to grow, symptoms are going to get a lot worse. We can identify this with a CT with contrast. I think that's the only time we talk about contrast, but CT with contrast because that adrenal gland has a lot of blood supply. So if we highlight that kidney the adrenal gland with a large amount of blood supply, by giving contrast, we're able to see that a lot better. How do we check for this? So we can do a plasma fractionated free metanephrines. So essentially what that means is that when a patient has this, right, and they have epinephrine and norepinephrine, those break down into what are called metanephrines, right? That's the breakdown product of epi and norepi. Those hang around longer, so you're able to draw a patient's blood, and if you see those, and if it's elevated, you see the breakdown products of epinephrine and norepinephrine, that tells you, hey, maybe it's the pheochromocytoma. The problem with trying to actually trying to find epi and norepinephrine in the blood, not the metanephrines, is that those break down quickly. So unless they're having like an acute attack right now when you're drawing the blood, you're not going to see high levels of that. But what you will see are the breakdown products of them. They hang around longer. If you have an elevated free metanephrine via plasma, the next thing to do is to confirm that. You have to confirm it. And with that, we're going to do a 24-hour urine fractionated catecholamine metanephrine. So with the urine, even though the epi and norepi are being broken down, some of that's not broken down, and we actually can excrete that. If we can catch the epi and norepi in the urine and the breakdown products, and if they're elevated, that tells us that there's a pheo. And then typically, once we do that, then we'll go to the CT and then try to find the tumor. How do we treat this? We remove the tumor. If we remove the tumor, the patient's better. This is one of those rare cases where we can treat hypertension with surgery. All right. Question for me about anything? No? Is that a lot? All right. If you guys have questions, come talk to me. Next time I see you guys is Friday. My goal was to try to get through all the lectures this week, but it's not going to happen. So we will meet Friday, and then we have virtual on Monday, and then that'll be the last, hopefully last time we lecture. But I'll still be around, so if you guys have questions, I'll find